Yes, multiple knees. You're right. I always say flight, but you're right. Yep, I need multiple me's. Are we ready?
Yes.
Cool, 3:10. Right when we normally start, 10 minutes in. All right, did you hit record? Okay, we're recording. Excellent. Welcome everyone to our class on treating broken bones. How it is going to work is that I'm going to run through informational class, teach a couple techniques on camera, and then it is going to turn off the hybrid session, turn off the camera, and you'll all actually get to practice with us for the practical. I'm going to try and run through all of the information really rapidly so that we have lots of time to practice with the practical. We'll see how fast I can go. It's kind of how fast can I talk. Before I get started, I want to remind everyone that we are Sanctum of the Craft. We are an anarcho-socialist witchcraft collective of street medics, as well as a seminary and church. No, you don't have to be a witch to make use of anything that we teach. We welcome people who are of every religion and spirituality, so long as they can welcome everyone else. We don't care if you are opposed to witchcraft, if you don't like that we're witches, just as long as you are learning how to help people. That's what matters to us. I am a street medic myself. I have been practicing for decades now. Ian is a street medic. He's been practicing for decades, although he primarily is my blocker. He's the person who makes sure that nobody interrupts me when I'm helping someone else. Not that you can't do street medic stuff on your own, but generally you serve as a blocker because you're 6'5" and 210 pounds. Okay, we're gonna go ahead and just run through this. If anyone has any questions, by all means, if they're a quick, short question, raise your hand. If it's a really detailed question, maybe wait until after. All right. Musculoskeletal injuries are extremely common. Every year, about 6 million people in the United States seek treatment for a broken bone. That's a broken bone severe enough that they actually went to the ER, went to quick care, etc. Musculoskeletal injuries are also fairly easily identified due to their 3 primary symptoms, which are pain, swelling, and deformity. They are also very rarely fatal. Street medics provide emergency temporary assistance directly after the physical trauma, generally in the form of identifying the injury and contacting emergency medical services. However, at times that care will extend to splinting and evacuation with a person to where emergency services can reach them. Broken bones are considered of less importance than life-threatening injuries, which we'll get to when we get into the XABCDEs. I want to note here that one of the reasons that we are teaching this class like this month and prioritizing it over other things is that recently at an anti-ICE protest, a protester had their collarbone broken by ICE, and ICE would not allow EMS in to collect the injured person for 40 minutes. And EMS and ICE got into a bit of a tussle over this. This is likely to increase in commonality. ICE is breaking people's bones, and ICE is denying them medical treatment. So as street medics, we are now going to have to be prepared that EMS might not be 10 minutes away. They might be hours away. Does that make sense? Okay. What is the musculoskeletal system? This is a very quick review. It consists of part of one bodily system and the entirety of another. Part of it is the muscular system, which consists of skeletal, smooth, and cardiac muscle. The muscular system is a system of muscles that runs throughout an organism in order to move the organism and stimulate the function of internal organs. Skeletal muscle is what we're concerned with today. We're not really going to get into smooth muscle or cardiac muscle. So skeletal muscle attached to the skeleton but is not considered part of the skeletal system. Thus, the systems are often combined and called the musculoskeletal system. It is responsible for moving the body via contracting or relaxing. It is almost entirely controlled by the somatic nervous system, and it requires conscious control. There are exceptions to this. The skeletal system consists of bones, tendons, ligaments, cartilage, and joints. A skeletal system for animals can be an endoskeleton, like in humans, or an exoskeleton, such as insects and arthropods, less relevant for today's class. It is responsible for the structure and support of the body and the organs, movement, blood cell production, calcium storage, endocrine regulation, and the protection of organs from damage. In humans, damage to the musculoskeletal system may indicate that there are more significant injuries to the organs that are protected by the bones. There are 206 bones in the human body. It is a myth that AFAB people and AMAB people have a different number of bones. I have heard this my entire childhood, that AFAB people have more ribs than AMAB people because Adam's rib was used to make Eve. This is bullshit. That there's no biological anything to support that. The skeleton is divided into the axial skeleton and the appendicular skeleton. The axial skeleton is composed of the bones of the central axis of the body. This is the vertebra, the spinal column, the skull, the ribs, and the sternum. Breaks to portions of these are beyond the scope of this class. That is going to be covered in a class on spinal injuries, head injuries, because you are not going to splint a broken skull. That's not how you deal with that. The appendicular skeleton consists of the bones of the upper and lower extremities, as well as the pectoral girdle, consisting of the scapulas, shoulder blades, and the clavicles, the collarbones, and the pelvic girdle. The shoulder girdle is the base of the upper arm, consisting of the scapula and the clavicle, which work together to keep the shoulder joint functional and also to serve as sites of muscle attachment. The muscles that attach there allow the upper arm to flex, extend, move the arm away from the body, which is called abduction, and move it back to the body, which is called adduction, and to rotate the arm. The upper extremities consist of the bones of the upper arms, the forearms, and the hands, as well as the joints of the shoulders, the elbow, the wrists, and the hands. The upper extremities also serve as an important site of muscle attachments that permit extension, straightening or stretching, supination, rotating the forearm upward, turning the palm of the hand towards the sky. This is supination. You can think about this as like if it can cup a thing of soup. That is supination. Right, where was I on these notes? Why have I lost my place? Okay, turning the palm of the hand toward the sky, and flexion, the action of a joint that causes the angle between the two bones it connects to decrease, bending that body point. This is flexion, the ability to do that. And pronation, a movement where the forearm and hand rotate inward, some of which come from the shoulder girdle and other of which start further down on the upper extremity. Many muscles, bigger and smaller, run through the upper extremities, as well as tendons, nerves, and blood vessels. Most of how the human hands function comes actually from muscles and tendons that come from the forearms down into the hands, rather than from the muscles in the hands themselves. This is why a break in the upper arm can actually disrupt hand function, because it's, what? Sorry, what did I say?
Upper.
Oh no, upper arm too.
Well, yes, but you pointed here.
Yes, thank you. I know what I'm doing. I'm fine. Everything's fine here. The pelvic girdle connects the torso with the lower extremities. The pelvic girdle is incredibly strong and has multiple sites where large muscles attach to it. The muscles allow for the flexion of the legs towards the torso, or the torso towards the legs. It's why you can go like this, and why your legs can do that too when you sit down. Foot supination, not desirable if it goes too far, pronation, abduction, and adduction. So what's a fracture? A fracture is a break in the bone. Sanctum of the Craft medics have heard over and over again, it's not broken, it's just a fracture. Or is it fractured, or is it broken? A fracture is a break is a fracture. They mean the same thing. I'm not sure, I think this might have come from movies, where they're like, oh, it's not broken, it's just a minor fracture. What? That is a break. Anyway, they occur when a force, direct or indirect, is greater than the strength of the bone. During healing, bone-forming cells that come from the bone marrow, called osteoblasts, go to the fracture and they form what's called a callus. The osteoblasts form a matrix called an ostoid of collagen fibers, proteoglycans, and growth factors, where eventually calcium will form as the framework to remodel the bone. The callus is initially very weak, and it is very easy for a bone to be rebroken again during the very early stages of healing. Then as the bone heals, there's a brief period where the bone is stronger than it was originally, but that actually doesn't last for very long. It is a myth that a previously broken bone is stronger than it was previously. It just regains the same strength as the rest of the bone, as long as that person has adequate nutrition and no complicating health conditions that would cause it to form weaker than it was before. If someone is very poorly nourished, they're malnourished, they're undernourished, and a bone is healing during that period, that bone may actually heal weaker than it was. There's a reason why you need to have adequate nutrition while you're healing. People at more risk for bones to break are people who are malnourished and undernourished. People who are elderly often have decreased bone density, and people who have diseases or medical syndromes, medical disorders that cause weak or brittle bones, one of which is literally called brittle bone disease. So what causes musculoskeletal injury? Skeletal injury is caused when the bones of the skeleton are impacted by forces that exceed their limitations. Common causes of broken bones include falls, motor vehicle crashes, and athletic activities. Direct force. If an object strikes someone, it will transfer its energy at the point of impact. If the force of that impact is greater than the strength of the tissues that it contacts, it will cause injury. In the case of a bone breaking, direct force can exceed the strength of the bone and cause a fracture. If the impact is on or near a joint, it may also dislocate the joint. This may or may not also cause a fracture. Sometimes the soft tissues in the area are bruised, lacerated, or even punctured by the object that applies the direct force. In the case of a penetrating injury, such as one caused by a bullet, the speed of the penetrating object has more influence on the force than the size does. A high-velocity penetrating injury will likely cause a fracture if it connects with bone in addition to soft tissue damage. So you as a medic, what is a penetrating injury that you might expect to see at a protest? A stabbing. Okay, I got stabbed at a protest. Anybody else? Penetrating trauma. Fall on a sharp object. Gunshot, yeah. There have been shootings at protests, and if a gunshot hits a bone, it often breaks that bone. Okay. An impalement injury may fracture a bone if it connects with the bone, in addition to the soft tissue injury it causes. Impaling objects must always be left in place and removed by medical professionals, even if they have broken a bone. Do not pull out a knife that has been used to stab someone. Definitely do not pull the knife out, go, shit, I wasn't supposed to do that, and stick the knife back in. Now you've stabbed them twice. Indirect force. If force is applied to one region of the body, but the injury occurs in another region of the body, that is referred to as indirect injury. The force is transmitted through the skeleton until it reaches an area that is weaker than the other parts of the skeleton that the force traveled through, at which point a fracture occurs. Forces can be transmitted along the entire length, even of a very long bone, or through several bones in series. When force travels through several bones in series, it can cause an injury anywhere and in multiple places. This is very often seen in one of the most common injuries, falling onto outstretched arms. Often a bone in the hand, called the scaphoid bone, is fractured by direct force, but then that force radiates up the distal ulna and radius, sometimes fracturing both, then up into the shoulder, where it either fractures or dislocates the shoulder, and sometimes also fractures the collarbone as well. Twisting injuries, as are often involved in sports, can cause spiral fractures of the bone. This occurs when one part of the limb makes direct contact and then remains fixed, while torsional force travels down the bone. The resulting torsional force can tear tendons and ligaments, as well as breaking the bone in spirals along its length. I actually had this happen to me when I was 11. I spiral broke my leg from the growth plate to the hip. Yeah, I was in a cast for a year. Started at, like all the way up hip height and then slowly worked its way down the leg. So I was in a wheelchair for 6 months and on crutches for 6 months. Great year, wonderful. And that happened during a fight because I got flipped over someone and ended up trying to stick that landing. Sometimes it's better to fall. Okay. Stress fractures, also called fatigue fractures, are caused by repetitive stress, which causes microcracks, generally in areas with deficient or insufficient supply of blood. The microcracks in the cortical bone result in an imbalance of bone resorption and formation, slowly weakening the bone further over time. Associated fractures. Some fractures commonly occur at the same time. These are called associated fractures. If one of them is present, the other one is likely to be. A scapular fracture, a fracture of the shoulder blade, often co-occurs with a rib fracture, a pulmonary contusion, and a pneumothorax, which is punctured lung. Not a good time. Scaphoid fracture. often occurs with a wrist, elbow, or shoulder fracture as well. A pelvic fracture often occurs with a lumbosacral spine and other long bone fractures, intra-abdominal or genitourinary injury. A hip dislocation almost always co-occurs with a fracture of the acetabulum or the femoral head, and a femoral fracture often occurs with a dislocation of the ipsilateral hip. A patellar fracture often occurs alongside a fracture or dislocation of the ipsilateral hip. A knee dislocation often occurs with a tibial fracture, and a distal pulse may also be absent. And a calcaneal fracture often occurs with a fracture of the ankle, lip, leg, hip, pelvis, lumbar spine, and the other calcaneus. So you will often find that if one thing is broken, something else is also broken. If someone has fallen, for example, and they landed like this, you want to assess that whole arm very thoroughly. Fracture types. I'm not going to get into really detailed on this, like what's a green stick fracture, etc. I'm going to do this very shallowly because we don't have a lot of time. Fractures are classified based on the direction that the break travels through the bone, the number of breaks on the bone, and the number of layers, which are the cortices, involved. Fracture can be classified based on displacement. Fractures are sometimes classified based on whether it has displaced the bone. A displaced fracture is a broken bone where the broken pieces have moved out of alignment, often causing a gap at the fracture site. Symptoms can include severe pain, swelling, bruising, and a visible deformity. Deformities of the extremity, the limb, might be angulated, rotated, or shortened. An angulated displacement of a fracture means that each end of the fracture is not aligned in a straight line anymore, so there is an angle between the pieces. That angulation can be on the frontal plane, also called the coronal plane, which divides the entire body into the front, the anterior, and the back, the posterior planes. To visualize a bone according to the frontal plane, one can imagine looking at it from the front or the back. So this would be the front of my body, and this would be the back of my body. That angulation may be on the sagittal plane, also known as the median plane, which divides the body into left and right sides. So, splitting it down the middle. It can be angulated on both of those simultaneously if the bone has been moved pretty significantly. Fracture classification can also be based on open versus closed, and as a medic, this is the one that's really concerning for us. Fractures can either be open or closed. In a closed fracture, the bone does not penetrate through the skin. In an open fracture, also called an exposed or compound fracture, there is a break in the skin from the transferred force or from the broken bone poking through the skin. Please note that even if the bone doesn't visibly poke through the skin, if there is a wound through the skin, it's still considered an open fracture. The key is that there's a communication between the broken bone and the external environment. Even if the wound to the soft tissues was caused by an object rather than by the bone itself, it can create a wound that goes all the way to the fracture site and communicates bacteria and other foreign matter from the exterior of the wound into that bone, which leads to the risk of a bone infection, which is a very, very serious thing. Put more simply, if there is a break in the bone and a skin wound that exposes that break to the environment of the outside world, that's an open fracture. Even very small skin punctures caused by shards or fragments of bone poking out from the inside qualify an injury as an open fracture. Open fractures lead to exposure to foreign contaminants, including dirt, microorganisms, which increases the risk of infection. Soft tissue damage can also hinder the normal healing process of the bone itself. Open fractures also have far more potential for blood loss than a closed fracture does, and this is where it gets very important for street medics. Open fractures often result from high energy transfers of force, which causes more soft tissue injury. In a closed fracture, the blood vessels surrounding the fracture can be damaged, leading to a hematoma, which is a localized collection of blood outside the blood vessels typically caused by trauma or injury. But that hematoma is kept compressed by the inflammation of the injury, which slows the bleeding and limits the size of the hematoma. In an open fracture, that pressure and compression is absent, and so the blood isn't slowed, it isn't halted, and it can flow away from the wound, leading to higher blood loss. An example of this is a femur fracture, a break in the thigh bone, the longest and strongest bone in the body. Because of the major blood vessels that lie alongside the femur, a femur fracture is very dangerous. The blood vessels can be broken by the force that caused the fracture, or the fractured bone itself can actually cut the blood vessels. A broken femur can sever the femoral artery. In a closed femur fracture, blood vessels that are severed can hemorrhage 2 pints, so 1 liter of blood, before the pressure builds up so much that it tamponades the bleeding. Tamponade of the bleeding refers to a condition where excessive fluid accumulates in a closed space, exerting pressure on surrounding tissues or organs. In this case, the pressure is enough to halt further bleeding, which is good because 2 pints or 1 liter of blood loss is enough to trigger hemorrhagic shock in the average AFAB person. And in an open fracture, the pressure doesn't halt that bleeding. If the blood vessels are severed, a person can bleed to death from the bleeding associated with a femur fracture and other open fractures as well. The two that are of major concern for bleeding to death are a femur fracture and a pelvic fracture. If someone has broken their pelvis and it's an open injury, there is a major chance that that person can bleed to death. This class is not specifically on pelvic fractures because they're very, very difficult to handle. So we're gonna focus really on broken bones in the extremities, in the limbs today. Signs and symptoms of a fracture: pain, a snap as a feeling of or as something that the person hears, a break as a feeling or something that a person hears, a deformity, a limb in an unnatural position, motion or bending where there is no joint, like, ooh, that arm is not supposed to bend right there. Most of the time we know that. Shortening, which occurs in fractures where the broken ends of the bone overlap one another, which is common in femur fractures because the broken femur cannot oppose the spasm of powerful muscles in the thighs. So the bone ends up like jerking up and overlapping itself. Swelling, ecchymosis, which is a discoloration of the skin resulting from bleeding underneath, typically caused by bruising and which is flat. Hematoma, a collection of blood under the skin which is not flat. Guarding or protecting of the area. Someone will be like, I don't want you to touch this. Loss of use, tender in response to palpation, and crepitus, which is a grating or grinding sound or sensation caused by the broken bones touching each other. You can actually hear it sometimes when you're touching a broken bone. Yes?
Do we want to talk about tuning forks?
I have read so much contradictory information on that. It has worked for us repeatedly, and then I go online and people are like, that's a myth. And I'm like, is it though? Because it's definitely worked for us. Okay, so basically, they used to teach street medics that they should carry a tuning fork with them, and that you hit it on something and then you touch it to the broken bone, and if the person screams, that's a broken bone. But now people are like, oh, that's a myth and it doesn't work. But we have definitely used it in the past to be like, yeah, that's broken. So I don't know. Unknown. If I don't know something, I will just tell you. In an open fracture, you will also find a laceration, which is a cut, bleeding, and possibly exposed bone, although sometimes the bone initially protrudes and then retracts back in. That happens a lot with a femur thing because it initially protrudes and then it sucks back up and overlaps itself because of the contraction of the muscle. So the medic must contact emergency services if the person is unresponsive, lost or is losing consciousness, if the suspected broken bone is in the head, neck, back, hip, pelvis, or femur. They cannot immobilize the injury at the scene by themselves. There is severe bleeding. The area below the injury is pale, cold, clammy, bluish, or purplish, or there is a bone projecting through the skin. If a child or nonverbal person refuses to put weight on an arm or a leg, won't move the arm or a leg, or the medic can clearly see a deformity, the medic should assume they have a broken bone. And for a child presenting with a broken bone, even if the adult is like, no, don't call, I'm just taking them home. Unless the adult with that child is telling you, I am going to take them to the ER, or I am going to take them to quick care, you have to call. If they're saying, no, it's not broken, I'm just gonna take them home, this is none of your business, call EMS. Signs and symptoms of dislocations. Pain, pressure, loss of motion at the joint, a frozen or rigid joint, deformity, an extremity hanging unconnected in the skin, Tingling, numbness, weakness, absent distal pulses if the dislocation is putting pressure on an artery. Because a dislocation can put pressure on an artery, it is important to check a person's pulse prior to and after splinting to make sure the splint isn't putting additional pressure on the artery. But honestly, you should be doing that anytime you splint someone. Take their pulse before you put it on, take their pulse after, keep an eye on it, make sure it's not turning white, make sure it's not getting cold. You want to make sure that blood is still getting to those tissues. Sprains. Sprains are injuries where the ligaments are damaged. They may be stretched, partially torn, or fully severed. They are usually caused by a joint being twisted past its normal range of motion, which causes a temporary subluxation. Sprains, dislocations, and fractures can all co-occur. This is very common in injuries to the ankles and shoulder. If someone at a protest sprains their ankle, they may also have broken one of the small bones in their foot. If someone at a protest falls and they land on their arm, they could very easily have sprained or dislocated their shoulder and also fractured their wrist. They may have fractured their elbow. You will often see these injuries occurring together. Signs and symptoms of a sprain. Type 1, which is a stretched ligament, is mild pain, tenderness when palpated, slight swelling, discomfort with pressure, and functional with minimal pain. Type 2, which is a partial tear of the ligament, is moderate pain, swelling, bruising, instability, and less functional with more pain. Type 3, which is a full tear of the ligament, is severe pain, swelling, bruising, instability, floppiness, inability to control mobility, and it just not being functional at all. Type 3 sprains require surgical intervention to reattach the ligament. If someone's ankle is like flopping and they can't put their foot back in the normal position, that's a surgical reattachment. There's not much we can do for them other than splint it and get them to medical care.
Right. If they say, I don't want to, it hurts.
Yeah.
That's type 2.
I will also note that having both broken my ankle and sprained my ankle, I would take the broken ankle any day over a type 2 sprain. I screamed, and it takes a lot to make me scream. If there is a deformity of the sprained area, medics should assume there is a fracture. If there is no deformity, no joint or extremity incongruity, and the mobility is limited by pain, not by lack of function, then the injury may only be a sprain. Only, as if they don't take weeks to months to recover from. It can be very difficult in the field for a medic to differentiate a sprain from a fracture. If the injury was associated with a lot of force, it is just best to assume a fracture. Either way, if the injury is severe enough for the medic to be intervening before emergency services can diagnose, the treatment is the same: immobilize the area with splinting. Strain. A strain is a pulled muscle or tendon that results from either too much stretching, too much contraction, or too much torsion. It is possible for a strain and a fracture to occur at the same time. At protests, the times I've seen strain are when people have been like fighting with the cops, like being hauled around by cops, thrown on the ground, arms pulled behind their back, that kind of thing, or when they're fighting with counter protesters and the same thing happens, like arms get pulled out of position. Oh, right, that's, yes, I forgot about that. I want to note here that I keep having people be like, oh, it's just strained. Strains can be very serious. There's 3 kinds of strains. Grade 1 is mild. It's a mild overstretch. There's a microscopic tear of the muscle fibers. There's minimal damage, slight pain, slight swelling, possible light bruising, possible light cramping that goes away. The loss of strength and the range of motion is very mild, and they heal in a few weeks. You've probably had a strained muscle at some point in your life, right? You can think about what that feels like. Yeah, if you work out too hard. Yeah, I definitely have given myself strained muscles by working out too hard. Grade 2 is moderate. This is a partial tear of muscle fibers. This is more extensive damage, some loss of strength, a more significant decrease in range of motion, and worse bruising. Possibly a visible or felt lump or knot in the injured muscle, and possibly more severe cramping. Weakness and pain are probably going to be increased, and they can take a few months to heal and may require physical therapy as an intervention. Grade 3 is a severe strain, and it's a complete rupture or tear of the entire muscle or tendon. They cause severe pain, significant bruising, swelling, and loss of function, and you may be able to see or feel a gap in the muscle where it's actually torn and like retracted away from the other end. They generally cause a complete loss of strength and often require surgery to repair the muscle. Yun is familiar with an injury at certain protests where someone's scapula gets torn free of the muscle. So it ends up fracturing the shoulder blade and ripping the muscles that hold it in place. That is a nasty injury to feel under your fingers. And Ian is more familiar because they teach about that in massage therapy.
Yeah.
Okay. In strains, the differentiation is that the pain is often from the lack of deformity of the bone or joint. I don't think. In strains, the differentiation is that the lack of pain is... What on earth happened to that sentence? Okay. I'm just going to say it. Generally, you're going to have a lot of pain, but not a deformity in the bone. That's the differentiation. Additionally, there may be a visible or felt lump, knot, or gap that is present in the muscle, not in the bone. Now, in the field, it can be very difficult to tell, like, am I feeling muscle or am I feeling bone? I can feel a gap here. Is that in the bone? Is that in the muscle? But on the bright side, again, in the field, you're not trying to necessarily diagnose them. You are going to be splinting regardless if they're unable to move that limb without injuring themselves. Okay. Scene assessment. We teach an entire class on this, but I'm going to run through it very, very quickly here because it is important. Anytime a medic encounters a person they intend to assess who has become injured, they have to assess the scene first. This can be done very quickly, but it's a vital self-protection step that ensures they will be able to help the person they want to assist. Although fractures can appear significant and frightening, most are relatively non-threatening. They are rarely going to be the immediate cause of someone's death, although there are exceptions for multiple broken bones that are related to large transfers of force, often resulting in internal bleeding, and for cases where an open fracture bleeds heavily and the person is at risk of bleeding to death. The first aspect of scene assessment is safety. A medic has to check if it is safe for them to approach, if it is safe for the person who is injured to remain where they are, and if the danger is to others present in the area as well. They need to check for environmental factors that would make it unsafe for them to enter. The danger of more falling objects, fire, floodwaters, rapidly speeding traffic. The police are marching this way with their horses. You know, think about what you're looking at. If the scene is unsafe, they need to check if there's anything they can do to make it safe. If there's a fire, can they put it out? If there's traffic speeding by, could they put out flashers to redirect traffic, etc. A medic should not enter the scene if it will endanger their life to do so. If the scene is not safe and there's no way to call for additional help to make it safe, the medic should And if there is a way to call for additional help to make it safe, the medic should do so as quickly as possible and provide assistance as soon as they can. This is one reason to have a blocker. A blocker can sometimes protect you while you run into a place that's not necessarily safe. Another aspect of safety is exposure to bloodborne illnesses. Skin injuries may result in the medic being exposed to blood and other bodily fluids. Depending on the severity of the bleeding, a medic may need to use gloves, a mask, and an eye shield. The medic should avoid contact with bodily fluids to any open wounds on their own body or to their mucous membranes. If there is no other option and the wound is life-threatening, the medic may choose to assist an injured person without adequate protective equipment. If the medic is exposed to blood from the person they are assisting and that person has an unknown medical history to them, they should, as soon as possible, clean the affected area with soap and water and flush their eyes, nose, or mouth with water or sterile saline if blood got into them. Then they should report that exposure to medical personnel and receive a medical evaluation, possibly including blood tests for them and for the injured person to determine risk and potential necessary follow-ups. For example, they may be given post-exposure prophylaxis, a medication that can significantly reduce the risk of HIV infection. Assessment of the injured person. The first step to assessing the injured person is to make sure there's no immediate threat to them. The medic should assess the person's mechanism of injury, which refers to how the injury occurred, the forces involved, and the potential severity of the injury. In some cases, this is really simple. A fall where someone put their hand out to catch themselves, a broken bone from someone being pushed to the ground. The injury may not be severe enough to have more complex symptoms, and the assessment can proceed to how to manage the injury. In cases of more severe injury or injury from an unknown cause, the assessment is much more complex. This can occur if someone has hurt themselves more severely or if the soft tissue injury is complicated by more complex injuries, like those that are caused by a beating and thus involve contusion, concussion, crush injury, compromised airways, etc. Sorry. The medic should rapidly assess if the individual is in an altered state of consciousness, if they have compromised breathing, if there is uncontrolled heavy bleeding, or if they are exhibiting signs of shock, or if they are even unconscious or conscious. This should be done by checking the person's airway, breathing, circulation, disability, and exposures. These are called the ABCDEs. The medic should not focus on the broken bone at first and check for the critical problems in order. First is external bleeding. Is there severe, life-threatening bleeding? If yes, they should stop everything and put pressure on the wound or apply a tourniquet immediately. If that blood is spreading rapidly, and there is both a broken bone and spreading rapid blood, you're going to want to use a tourniquet. Do not attempt to wound pack directly on a broken bone. Okay? Just skip to the tourniquet. Airway. Is the person's airway open and clear? Are they choking or gurgling? Breathing. Are they breathing? Look, listen, and feel. The medic does not need to count the exact rate of their breaths. Just check if it's absent, extremely low, or extremely fast. Circulation. Do they have a pulse? The medic doesn't need to count it. Just check if it's absent, very weak, or extremely fast. Disability. What is their level of consciousness? A, alert. V, responds to voice. P, responds only to pain. U, unresponsive. Exposure. Carefully remove or cut away clothing to fully check the body for any other hidden injuries. Some medics use a small C at the beginning to stand for critical bleeding or an X for extreme bleeding. I tend to use X, XABCDEs. If someone is in immediate danger of bleeding to death, the risk of the assessment waits until that is addressed and they are no longer at risk of hemorrhagic shock. If the pulse is absent, the medic needs to take immediate resuscitative measures. However, if they are bleeding to death, that comes first. CPR comes when the bleeding has stopped. Otherwise, you are just helping their body pump all of their blood out on the ground. Head-to-toe assessment. A head-to-toe assessment should be performed after the XABCDEs to determine the nature of the person's injury. It should be performed in its entirety before treatment is begun, but should not be performed if the person requires immediate treatment for life-threatening injuries, such as in cases of compromised breathing or severe hemorrhage. The responder performs a head-to-toe assessment to determine the location of all the injuries, the extent of those injuries, and the treatment that the person needs. The memory tool for this is DCAP BTLS. That is just DCAP BTLS, that's how you remember it. This acronym guides a medic on what to look for and feel for as they check the body from head to toe. D is deformities. Does anything look misshapen, crooked, or out of place? C is contusions. Are there any bruises? A is abrasions. Are there any scrapes or grazes? P is for puncture. Are there any stab or puncture wounds? B is for burns. Are there any burns? T is for tenderness. Does the person feel pain when you gently press on an area? Lacerations are L. Are there any cuts or tears in the skin? And S is for swelling. Is any area puffed up or swollen? Understanding the mechanism of injury, the MOI, what caused the harm, will help provide additional information on what injuries are likely. For example, a rubber bullet is likely to cause contusions, tenderness, and swelling, as well as possibly lacerations and even a puncture wound. So if the MOI is rubber bullet, the head-to-toe assessment will be informed by that information, and so will treatment, which is why it's a lot easier to help a conscious person than it is an unconscious person. They can tell you things. Patient assessment if they are capable of answering questions. Sometimes the medic knows the injured person, their family member, a housemate, a friend, a coworker, a volunteer they work with, or even another medic, but other times they are a stranger. First, obtain consent. Yes, even if the person is a member of the medic's family, they should still ask before they assist them. What?
There's a slide issue.
What's the slide?
We'll deal with it.
Okay.
There's overlapping text boxes.
Oh, sorry.
Keep going.
Secondly, prevent further injury. The shock from being injured, even if the medic perceives the injury as minor, may cause an injured person and onlookers to pass out. It is recommended that the injured person be placed in a resting position. If there is doubt as to how well the person's coping with their injury, they're dizzy, they're lightheaded, they've gone white, they're blanking in and out, they're not really answering your questions clearly, that position may need to be fully supine, which is a fancy way of saying laying flat on their back, staring at the ceiling or the sky. Bystanders may also need to be directed to sit or lie down if they show signs of presyncope, which is another fancy way of saying they look like they're about to pass out. The medic should then obtain a brief description of the current injury and how it occurred. They should ask the person if they're dizzy, lightheaded, nauseated, and are having trouble breathing. To gather information, use the acronym SAMPLE. Signs and symptoms are for the S. What are they feeling? Pain, nausea, dizziness. A is for allergies. Are they allergic to any medications? M is for medications. Are they taking any prescription drugs, especially blood thinners, critical if bleeding, or heart medications, critical if they are in shock? Pertinent history. Do they have any medical conditions that affect their bones, like osteoporosis or a bleeding disorder? Last intake. When did they last eat or drink? And events. What happened? How did the injury occur? Relevant medical history in the case of a fracture involves whether or not the person has a medical condition that impacts the health of their bones, osteoporosis, brittle bone disease, bone-related cancers, etc. If the person is bleeding, the medic should ask about any medications that thin their blood, any anticoagulants, and if they're showing signs of shock, they should ask if they're on medications that affect how that body handles shock, including beta blockers, calcium channel blockers, antidysrhythmics, and nitroglycerin. For broken bones specifically, the medic should remember the 6 Ps of musculoskeletal assessment. These are pain, paralysis, paresthesias, which is numbness or tingling, pulselessness, pallor. If they are pale, gray, or purplish, that is not a good sign, and pressure. When assessing the pain of a broken bone, they can also use OPQ-RST, which is a mnemonic to help them remember onset of pain, provoking or palliating factors. What makes it worse? What makes it better? Quality of pain. Is it sharp? Is it throbbing? Is there a sensation of pressure? Regions of pain. Where does it hurt? Severity of pain. You know, this is a normal amount for you, or is this the worst day of your life, and everything in between? Time. The duration of how long they've been experiencing it. Palpation of a fractured extremity should include the injury site and the injury site above and below it, the region below and the region above. The medic should look for the signs and symptoms of a broken bone as they go over the entire area, paying special attention to instability, deformity, abnormal bone or joint continuity, displaced bones, crepitus, and reaction to pain from the injured person. The medic should note if there is a change in pulse between the injured extremity and the uninjured extremity, as that indicates arterial injury. So if on one arm, their pulse is normal, and then you go to the other arm and you're like, I can't feel the pulse here. That's not a good sign. That's generally that there's arterial injury, either from pressure or severance. Other signs of arterial injury include an expanding hematoma, a vibration on the site of injury that matches the patient's heartbeat, and difficult to staunch bleeding in an open fracture. Any instability in the pelvic girdle, pelvis, should be communicated to emergency medical services as quickly as possible. If instability is found, the physical examination should be halted, as manipulation of a pelvic instability can disrupt blood clotting and worsen internal and external bleeding. Someone has broken their pelvis, and you're touching them, and you're like, why is one side of your pelvis flexing and the other one is not? That is a stop touching that. Leave it alone. Wait for EMS. Keep the person stabilized for shock. The medic should always monitor and treat for shock, especially if the injury was caused by a bad fall, a beating that can cause internal injury, or if there's heavy bleeding. Children have a lower tolerance for injury than adults, especially blood loss. They may appear fairly stable and normal, though upset with good blood pressure and pulse, and then suddenly collapse. Children with fractures may not want anyone to see, touch, or splint the injury. Medics should always obtain consent from a parent, guardian, or caregiver if they are present before touching any broken bone. The parent, guardian, or caregiver may also have to be managed for their own upset reaction to their child being injured. If possible, a parent can be asked to hold an injured child while they are splinted. Always have an injured child sit down for treatment. Do not try and treat a child who's standing up. Really, you should extend that to elderly people as well. Pregnant people will naturally have a faster pulse, lower blood pressure, and often nausea, so evaluation can be more complicated. We recommend that their symptoms be taken seriously, even if they are presenting with signs that are normal for them being pregnant. We just don't automatically dismiss the altered state of someone's medical being because they're pregnant. Sometimes clothing may need to be shifted or removed to make a head-to-toe assessment possible. In this case, the medic should ideally be of the same gender of the person they're assessing, but that's not always possible. Culture and religious beliefs regarding the removal of clothing and inspection by a person of another gender must be respected. We encourage cultural competency training. And clothing must never be removed without consent unless the person is unconscious and treatment is necessary to save their life. And you remove only as much as you need to and stop there. One thing that drove me nuts looking for photos for this class is how many people left the shoes on, the people of the that they were splinting. I'm like, no, the shoe comes off. We'll get into that, but like so many pictures online for splinting had shoes on. Anyway. Conducting the assessment. If the person is unconscious and unresponsive, the medic should always suspect brain and spinal injury and be very careful when handling the head and neck. The responder should go from the head to the toes while conducting a head-to-toe assessment, checking the head, neck, shoulders, chest, arms, hands, abdomen, pelvis, legs, and feet in that order. Head to toe is called head to toe for a reason. The responder should look, listen, and feel for anything that is unusual. If they are uncertain if something is out of place or feels different, they can compare the potential site of injury to its mirror on the other side of the person's body or compare it to their own body. You can be like, this is what a normal collarbone feels like. Yeah, it's broken. While passing their hands over the body, they can check their own hands to see if blood has come onto their hands. This is especially relevant if they dress like I do. Why might it be hard to tell if I'm bleeding?
Black eye stain.
Yep, I wear really dark clothing. I wear really dark clothing because I keep getting blood on. So I've just decided my entire wardrobe gets to be black now. That, and I eat a lot of spicy food with chili oil and it gets everywhere. Okay. They can also check for clues, medical alert jewelry, the presence of medical devices such as insulin pumps or inhaler on a person who is unconscious. The medic should attempt to never cause new or additional harm while conducting a head-to-toe assessment. They should move a person as little as possible, as gently as possible, and basically the cardinal rule of being a street medic is give a fuck about the person you're trying to help. Don't hurt them. Give a fuck. Okay. Basic treatment. After an assessment has found a broken bone, the basic treatment of closed fractures is to immobilize the broken extremity with splinting. Cold packs can also be applied to slow down internal bleeding and to reduce pain. The treatment of open fractures also involves managing bleeding, reducing the chance of infection with the dressing and bandage, and immobilizing the broken bone with a splint. Cold packs can still be applied. They will actually help slow down the bleeding and reduce pain. Severe injury. If the medic finds that the person is unresponsive, unconscious, struggling to breathe, has a very altered pulse, or showing signs of shock, or is bleeding severely, emergency services have to be contacted. The person should be assessed for shock and should be treated for that. If there is bleeding and it is severe, control of that hemorrhage takes precedence over everything else. Medics need to make sure they don't focus on the distracting injury and miss a life-threatening injury. The phrase to help you remember this is life over limb. You put their life over the state of their broken limb. A broken bone is serious. Other conditions are immediately deadly. A visibly broken bone can be very distressing. It's easy to focus on it, but if there's heavy bleeding, take care of that first. If someone has multiple broken bones, they shouldn't be moved at all unless absolutely necessary. If there is no choice and the medic has to choose between using a long backboard as a full body splint while transporting the person to safety, or individually splinting each broken bone before moving the person on a backboard or blanket. The choice they make may depend on whether it's safe for them to remain where they are for long enough to individually treat each broken bone. I have seen medic guides say, if they have multiple broken bones, splint every single one of them before you move. If there is a reason it is unsafe for someone to remain where they are, floodwaters are encroaching, fire is encroaching, building in danger of collapse, police are headed this way and they're just trampling people with the horses like is happening in LA. You do not have time to splint every single individual broken bone. That's where you're going to use either a backboard that you have with you as a medical device, or you're gonna fashion one out of whatever you have. Yes, you can move someone in a wool blanket if you have to. If they have a lot of broken bones, you need to be aware that as soon as you've set them down somewhere, you've got to be treating and splinting. You do not have a lot of time to carry someone with multiple broken bones in a blanket because you are injuring them as you're doing so. Does that make sense? All right, we're gonna get into fashioning an emergency backboard out of a folding table in a little bit. Okay. Severe bleeding from an open fracture takes precedent over the splinting of the broken bone. The bleeding wound may need to be treated with a dressing and direct pressure until it is stopped before the bone can be splinted. This may be extremely painful for a person if the wound is directly over the fracture or has a bone poking out of it. If there's a bone poking out of someone and they are bleeding to death, I would actually say skip direct pressure, apply a tourniquet. Because putting direct pressure on that is probably not going to stop the bleeding, and it is going to hurt like hell. So just skip it. Go directly to the tourniquet above the injury. If they don't have the bone sticking out, you can trying with 10 minutes of firm direct pressure and seeing if the bleeding stops before you skip to a tourniquet. But remember, tourniquets now are safe. They're easy to use. As long as they are removed within 4 hours of being applied, there is no risk to the limb. And someone bleeding to death is worse than them losing the limb, even if it did cause them to lose the limb, okay? Which it doesn't now, because we get people to medical care a lot faster. All right. Once the bleeding has stopped, it can be bandaged. A bandage has to be secure enough. It should actually say it should be dressed. The dressing and the bandage have to be secure enough to control bleeding without restricting circulation to the injury. Swelling from fractures and internal bleeding can cause a dressing and a bandage to become too tight. The medic needs to monitor that tightness by assessing circulation, sensation, and movement of the bandaged area. A tourniquet may be necessary in combination with the splint in cases where bleeding cannot be stopped by pressure alone. The potential blood loss from fracture sites. For a radius or ulna, it's 150 to 250 milliliters. For an elbow, it's 250 to 500 milliliters. For an ankle, it's 250 to 500 milliliters. For a tibia or fibula, it's 250 to 500 milliliters. For the humerus, it's 250 to 500 milliliters. But for the femur, it's 1,000 to 1,500 milliliters. And for the pelvis, it's 1,500 to 3,000 milliliters. Hemorrhagic shock is most likely to occur with severe lacerations that damage vascular tissues, amputations, penetrating injuries, blunt injuries to organs, long bone or pelvic fractures, and multiple system injury. Hemorrhagic shock can occur from both external and internal bleeding. If a femur or pelvis is fractured, there's a very good chance that someone is going into shock. A factor in how hemorrhagic shock affects the body is how fast it happens. A person can donate 1 pint over 20 minutes and not necessarily feel adverse effects from doing so, but that same amount of fluid loss happened over a minute or 2 minutes, they're going to experience hemorrhagic shock. In the average American AMAB adult person, if they have lost just under 1 liter of blood, they are likely in hemorrhagic shock. This is the equivalent of 2 large beers being poured out onto the ground. For an average American AFAB adult person, the number is lower at approximately 750 milliliters. This is the equivalent of 1 bottle of wine poured out on the ground. Because infants and children have less blood than adults, they experience hypovolemia and hemorrhagic shock very rapidly. A 1-year-old child has approximately 2 pints of blood in their entire body, 950 milliliters. So they suffer from hypovolemia after a loss of only 3 to 6 ounces of blood, 100 to 200 milliliters. Keep in mind that the average glass of water in the United States is 8 to 10 fluid ounces to help put that in perspective. It is not a lot of water in a kid, or not a lot of blood. It should be noted that the symptoms of shock are not a perfect guide to assessing blood loss severity or determining treatment. Symptoms vary and no system of assessment is perfect. The signs and symptoms of shocks can be measured using a 4-stage system that is detailed in our guide on abrasions and lacerations, or using the compensated and decompensated model. I'm only teaching the compensated and decompensated model today for time constraints, even though I actually prefer the 4-stage system more and use it myself. This is faster to teach and it's faster and easier for you to implement. I recommend learning the other one as well. The compensated and decompensated model is best for rapid assessment in more chaotic environments. Compensated shock is the phase of shock in which the body is still able to compensate for fluid loss, which can be either losing water through like sweat, dehydration, etc., or losing blood from hemorrhagic shock. And it can still maintain adequate blood pressure. Decompensated shock happens when the person's body is unable to compensate for fluid loss and cannot maintain the brain and other vital organs. Compensated shock looks like anxiety, a sense of impending doom. I'm not kidding, that's a symptom. Not even just of this, it's also a symptom of other things. Agitation and restlessness, weak and or thready pulse, rapid pulse, cool and clammy skin, white or gray pallor, possibly with bluish or purplish lips, shortness of breath, nausea, vomiting, thirst, normal blood pressure. Decompensated shock looks like confusion, altered consciousness, possibly nonverbal, possibly unresponsive, labored breathing, thready or absent pulse in their extremities, ashen, mottled, or bluish or purplish skin, and low blood pressure. The first steps of treating this kind of shock is the same as proceeding to treat any injury. Scene assessment, ensuring the safety of the medic and the bystanders, standard precautions for bloodborne illness. If the person is conscious, continue with the patient assessment in a calm, compassionate fashion. If they're unconscious, you're going to go to airway constriction, breathing, heavy bleeding, If the person is conscious, help them get into a supine position. That's laying down, staring straight up at the sky. Do not allow the person to eat or drink something, even if they are very thirsty. The person should be kept warm with a shock blanket while waiting for emergency services. Most external hemorrhage can be halted with direct even pressure for 10 minutes. Once hemorrhaging is controlled and a sterile dressing or appropriate other bandage has been applied, they can be transported to the emergency department by emergency services. But if a person's bleeding cannot be stopped with firm direct pressure, it may be necessary to employ more direct pressure measures, including wound packing and using a tourniquet. In the case of treating a broken bone, we recommend applying a tourniquet, not wound packing, because you don't wound pack directly on a broken bone. Splinting. Splinting provides support to broken bones and prevents them from moving, which can worsen the fracture. Correctly splinting decreases the pain a person is in and reduces the risk of further damage to the bones, as well as the surrounding muscles, nerves, blood vessels, and skin. It also helps to control both internal and external bleeding. To apply a splint, properly see the injury in detail. This likely will involve the removal of some amount of clothing. Stop the bleeding if necessary. Apply a sterile dressing if necessary and bandage it in place. If bone ends are exposed, you just loosely place a moist dressing over them to keep the bones damp. Do not tightly dress the bones sticking out of someone. For one thing, it's excruciating, and for another, you're just introducing bacteria. Assess and record the PMS, the pulse, the motor, and sensory. Is there a healthy pulse? Are they able to move their extremities like their fingers and toes? Can they feel touches past the point of injury on the extremity? Apply a splint that immobilizes the bone ends and adjacent joints. Knees should be splinted straight if they are not already angulated. So if somebody's knee is going a weird direction, don't try and force it straight. But ideally, you want the leg, if you're splinting it, to be in alignment with the knee pointing the direction it normally does. Don't splint it at a wonky angle. Okay, where was I? Elbows should be splinted at a 90-degree angle. Do not cover fingers or toes with the splint. So this is how you want the elbow, like this, 90-degree angle. There are exceptions. We'll probably get into it with practical stuff, which is called swathing rather than splinting, which is where you actually strap the arm like this. And it's where it's so badly injured that it cannot be splinted, like this. And so you're immobilizing it by pairing it with the body. Okay, but splint firmly, but not so tightly as to occlude circulation. Take the PMS again, pulse, motor, and sensory. Monitor for changes in skin color, temperature, and condition. If possible, apply cold packs. If possible, elevate the splinted extremity to minimize swelling. Wait for EMS or transport the person to a safe location and to further assessment and where they can get quality medical care. Sometimes you're going to have to evacuate someone. Do not enter or probe into the wound to remove debris. Push exposed bone back under the skin. Move the patient before splinting unless there is an immediate danger to them if they are not moved. Should a medic ever straighten a bone? Generally, no. They should stay with the person, keep them stable until EMS arrives. But if EMS are significantly delayed, cannot reach a person, or the person has to be moved for their safety, the answer is actually sometimes. Doing so incorrectly can further worsen an injury. Additionally, the pain of doing so in the field is extreme, which generally outweighs the benefit of doing so if medical professionals are on their way. So if a long bone fracture is severely angulated, or if there's a loss of distal circulation, it may be more urgent to reposition a fracture. So someone has a broken bone and it's wonky. So say that this part of my arm is now going that way, okay? And I'm losing the pulse in that hand, and it's going away, and the whole limb is turning purple, and EMS is not 10 minutes away, they're 2 hours away, that's when you're gonna actually straighten a broken bone. Doing so incorrectly worsens it, so be careful. The medic needs to apply gentle traction and tension lengthwise along the bone, realigning the bone into a more natural position and improving circulation. They have to apply a firm grip and move nice and slow, nice and smooth, avoiding any sudden jerky movements of the extremity. If the person reports severe pain or is resistant to continuing, the limb may need to be splinted in the position it's already in, and the medic may need to just carefully monitor their pulse in that limb. I have had to actually do this to a broken bone a couple of times. I've also had to to relocate dislocations a few times. Every time I have been in a position where I had to, there was a damn good reason that I violated that. I would ordinarily say that you not do that. What? Yes, like the time your pinky was stuck in the Challenger drawer and you were screaming and crying and did not want any strangers touching you. In that particular case, yeah.
That's a good example of what to do when a kid starts to just do it.
Yeah, I just popped it back in and you were like, what? So, but we also then took you to the ER. So, okay, types of splints. Any device used to immobilize a fracture or dislocation is considered a splint. Medics should not allow the lack of a commercially made splint to cause them not to help an injured person. Rigid splints are any inflexible splint that can be attached to an extremity to maintain stability of that fracture. These can be a board, a piece of heavy cardboard, rolled up newspapers, a SAM splint, which I'm going to teach you all how to use today, or full metal splints that are secured with straps. It should ideally be padded to ensure even pressure. I have literally never in the field been in a position to pad a splint. Like, I could give them my t-shirt, I guess. I'm not, it needs to be long enough to be secured above and below the fracture site, not directly on it. Soft splints may be used if no other material is available. They can be fashioned from pillows and rolled up towels and blankets. I'm going to teach you how to do all of those today. Anatomical splints are fashioned in an emergency when other splinting material is not available. It is done for breaks in the legs. You can kind of tell why you can't do it for a break in the arm. The legs are straightened next to one another with a blanket or towel rolled up in between them. The two legs are then tied together at several places down their lengths, although not directly over the side of the break itself. Technically, in some wilderness survival guides, it'll tell you can do an anatomical splint by splinting the arm to the body. But then you can't have the person sit down. So, I'm going to say that's not ideal. Buddy splints. Buddy splints are used to splint injuries of the fingers or toes. Lex is familiar to this because that's what I did for him that day. They are a form of anatomical splint where the injured finger or toe is splinted to the uninjured one. To buddy splint, a gauze pad is placed between the digits and then they are taped together. Again, the tape should be not be placed directly on the break. Every martial artist I've known who's been very, very serious about martial arts breaks their toes at some point and just tapes it to the other toe until it heals. I'm not saying that this is what you should do, but I'm saying it's what every single martial artist I've ever known has done. So, what?
Easy way to get a bunion.
Yeah, easy way to get a bunion. Advanced splints, typically used by EMS. I'm really just mentioning these because medics should know what they are. They're generally not recommended for basic or street medic kits due to cost, complexity, or risks. One of these is called a pneumatic splint, also called air splints or inflatable splints. They're used to stabilize fractures of the lower leg and forearm. They should not be used for angulated fractures or fractures of a joint because they will forcibly straighten them and not always in the best way. They shouldn't be used for open fractures where the bone ends are poking out of the skin. They apply pressure and can minimize swelling and bleeding. We do not recommend that street medics utilize them as there are so many times they aren't appropriate to use because they need special devices to inflate them. They can't be inflated with like your average compressed air tank. And because if they are overinflated, they can cut off blood flow, and overinflation is very easy to do. Vacuum splints. A vacuum splint is a sealed plastic container filled with air and thousands of small plastic beads. It is wrapped around an extremity, a suction pump is attached, and it pulls the air from inside. That then compresses the beads so that the entire splint becomes like a plaster cast that conforms to the contours of a person's extremities. We do not recommend street medics utilize them as they need special suction pumps. They're expensive and they're difficult to use without causing further injury. Vacuum mattresses are used by EMS. They are essentially vacuum splints, but very large. They are applied underneath a person in the place of a backboard, splinting their entire body at once. It's often what they use if someone has a pelvic fracture. It's one reason to tell them when you're on the phone, I suspect a pelvic fracture, because then they can bring an air splint with them, a mattress-sized one, which is much better than them trying to use a scoop or a backboard for a pelvic injury. We don't recommend that people carry them even though they're really good for people who are elderly who've fallen, people with multiple breaks, people with really fragile bones, and people who have spinal column injuries, because they are huge. They are huge, they're difficult to operate in cramped or chaotic environments, they take up a lot of storage room in a kit and medic tent, they require a specialized suction pump, and they're very, very expensive. I'm talking like $1,000 to $3,000 for one. That's a lot for a medic collective to spend on a single item. Traction splints are used to provide a constant pull on a fractured bone, preventing the broken bone ends from overlapping. They're commonly used for fractured femurs as the strong muscles of the thigh involuntarily spasm and contract, causing the broken bone ends to overlap. They also help reduce blood loss from femur fractures by putting the muscles back into alignment so that they keep the blood vessels under pressure. They should not be used if the person also has fractured their lower leg below the knee, because it will actually pull those bones apart. So that's one reason why a medic who can't x-ray a bone shouldn't maybe necessarily be using them. They should not, they are somewhat expensive, they take up a lot of space in a medic's kit, and they should only be prioritized as an item to have in a kit if a medic feels they are likely to be providing support for people who will be greatly delayed in getting professional medical assistance. So if you're doing medic work out in the great wilderness, and someone's hours from a hospital, that's when you might want to add one of those to your kit. Otherwise, I'd say don't bother. Slings. A sling may be needed if the break is to the shoulder, the arm, the elbow, or the wrist. The sling holds the injured extremity steady against the chest wall, prevents it from being further injured by knocking into things, and takes the weight off the injured area. To apply a sling, first, splint the break. Follow all the steps for splinting. If the person can support their arm with their other hand, ask them to do so. Gently slide the triangular bandage underneath the arm so that the point of the triangle is under the elbow of the injured arm. Bring the pointed end of the triangle that is closest to the body around the back of their neck. Fold the other hanging pointed end of the triangle bandage up over their forearm to meet the other end of the triangle around the back of the neck. Tie or pin the two ends together. We will be demonstrating this on camera in a few minutes. Adjust the sling so that it's actually supporting the arm, tuck the point of the triangle in at the elbow or pin it so that it's also supporting the elbow, and keep the fingers out of both the splint and the sling so that the PMS can be checked periodically. If the person is very large, two triangular bandages can be tied together. Do not use a sling tied around the neck if the person has a neck injury. Okay, last couple things to cover, complications of fractures, and then we're going to get into the practical. Complications of fractures include peripheral nerve injury. If the blood vessels are damaged following a fracture, loss of blood flow can occur in the area of the body supplied by that vessel. This is called devascularization. Broken bones can also cut nerves, more common in injuries to joints. Splinting the injury in a correct anatomical position can help relieve pressure on nerves and prevent nerve injury. Compartment syndrome. In an extremity, groups of muscles are surrounded by a membrane called the fascia in a compartment. Each compartment can only accommodate a certain amount of swelling before it prevents blood flow from supplying the muscles in a compartment. This can lead to muscle ischemia and eventual muscle death. This can occur if bandages, splints, or casts are applied too tightly or tourniquets are left on for longer than 4 hours. It is a myth that open fractures cannot have compartment syndrome. This is one reason to monitor the pulse in an affected extremity and adjust as necessary to maintain that pulse. Crush syndrome. When a body part, like a limb, is crushed for a long time, typically 4 to 6 hours, the muscle cells begin to die. When the crushing weight is lifted, toxins from the dead muscles flood into the bloodstream. These toxins can cause sudden cardiac arrest from high potassium levels and kidney failure. A classic sign is tea-colored or cola-colored urine. This is complex. If someone has been trapped for many hours, medical direction is needed before freeing them. First aid involves managing the XABCs of the XABCDEs and prepping for rapid transport to a hospital. Oftentimes, if you find someone and they have had an injury crushing them for like 4 hours, you cannot remove that injury or that crushing thing. You have to wait for EMS to arrive to remove the crushing thing. Say again?
Inflictive instead.
Yes.
Just don't.
Just don't. Just manage them for shock and wait for EMS. I would say there's exceptions. You know, if someone is out in the wilderness and EMS is not coming, you have to make a choice. But blood clots. After a major injury, especially to the pelvis or the legs, a person is at high risk for developing blood clots. A clot can break free and travel to the lungs, causing a pulmonary embolism. A pulmonary embolism can cause sudden shortness of breath, chest pain, and can be fatal. In the field, treatment is supportive, including recognizing the signs and symptoms and providing rapid transport to a hospital. We can recognize pulmonary embolism. We are not the people who would treat it. Now, we can also say, okay, grandpa fell and broke their hip. We now need to be aware that they are at increased risk of an embolism because hospitals don't always actually inform people of that. My great-grandmother fell and shattered her entire shoulder into multiple bone fragments and had to have it reconstructed, and no one told her. She was at increased risk of blood clots forming after, and she kvetched about that for months because she was a street medic, so she knew. And she was like, nobody even told me. And I was like, yes, Grandma, I know. No one even told me. Yes, Grandma, you have said. Okay. Now we are going to get into actually demonstrating some things. The first part of that we're going to record and share on Zoom, and then we're going to turn it off and practice together. Yes, Lex?
When it comes to like right in the femur,
Mm-hmm.
that hip bone,
Mm-hmm.
the nodule that fits into the pelvis,
Yes.
if that breaks, is that considered a pelvis injury or femur injury?
If the top round bone, like what Ian has the cane made out of, breaks, that is not considered a pelvic injury. That is considered a femur injury. But if the socket around it that it slots into breaks, that's considered a pelvic injury. Now, any break to that area is a very big deal.
Yeah, because there's still the artery right there that you need to worry about, and like if that part of the femur breaks, the pelvis is probably going to break too.
Yes, generally. Because the pelvic girdle is not as strong as that top of that femur. That top of that femur is a stronger bone. So if that force broke that top of the femur, probably the pelvic is broken toe.
Consider it a pelvis injury in the field.
Yeah, also in the field, you're probably not going to be able to tell which one's broken. You're just going to be able to tell something in there is broken. I mean, like, one of the reasons Ian has a cane made from one of those is because it makes an effective weapon. That is a very hard bone to break.
It's not meant to break.
No, it isn't. Like to give you an idea of how he got that cane was it required a very strong saw to cut through the femur to give that portion of that bone to him.
Well, the bone saws that they use vibrations rather than actual
That's right.
strength. So.
Okay, so
Before you get to this, sorry, I'm trying to get full video for Zoom.
okay. Well, while you're fiddling with that, I will start pulling out materials for teaching.
Okay. Does someone want to turn on the lights? So we can turn on the lights.
Okay, so we're gonna start with the easy ones. These are Sam splints.
You get Sam splints.
I bought them.
How much were they?
A lot.
When you reimburse?
No, I bought that out of my own money. Now, Madar bought us a few, so that's okay then. We're gonna use the cruddy triangle bandages. I bought these only for teaching with. Do not use this brand. I bought them off Amazon. They're terrible. Okay. This is a triangle bandage. Can anyone guess why they might be called a triangle bandage? They're triangular. Excellent, good job. I recommend that you carry several of these in your kit because they are so useful. They are just ridiculously useful. They can be used to fashion a tourniquet. They can be used to fashion the sling or the swath. They can be used to hold in place dressings for bleeding wounds. They can be used for wound packing in a pinch. They're just ridiculously handy. Now, I no longer carry silk ones. I used to carry silk ones because that's what my great-grandmother used, but it turns out that silk can actually be not great for using as a tourniquet because it can get too tight and cut into the tissues.
Also, we have now stopped projecting, so you are good to see.
Oh, actually move around. Excellent.
If it's really high quality silk, it doesn't have much stretch. So.
Which one is that? Is that the shortest one? I want the shortest one. Yeah, okay. I'm gonna be using the 18-inch today. No, I want to start with the 9. And we'll use the 18 and the 9 today. Okay, So I'm going to pass around the 18-inch one. You all can feel it if you want to. These are what I recommend someone carry. They're super lightweight. They're very, very easy to use. And unlike...
Don't bend it back and forth too many times as we pass it around.
Yeah. Well, these won't be reusable after this class. These are just going to be considered sacrifice of the class.
Demo.
These are just demo. Once you've bent them a few times, you should not use them for a person. So these are just going to be sacrificed. So how they work, you want to make sure that the fingers are dangling off, okay? You can ask them to just wrap their hand around it if they're conscious, and you can ask them to hold it for you, and then you bend it up around the injury. Just like so. And then you would use either a triangle bandage or a gauze roll or duct tape or gaffer's tape or whatever you have to tie that on in several places. Now I have a watch on. That watch would get taken off because the watch is actually preventing it from conforming tightly enough.
Would you like a volunteer arm?
Yes. So I would ask him, sir, are you capable of holding this for me while I put your sling on? Excellent. Okay.
How easy is it to like cut off sections of
Very.
this one?
You can use trauma shears to cut right through it.
Oh, okay.
Yeah.
Cool.
Okay. When I talked earlier about having the elbow supported, this is what I mean. This goes over here, right? Okay. And then this end is going to go between the body and up over the shoulder. You are so tall, I would absolutely have asked you to sit down. And this comes up, and then you tie it here. Then, if you need to, you can pull this up and have it be providing additional support. You can pin it to their clothing, and it will actually help it stay in place supporting that elbow. There's a reason why triangle bandages generally come with pins included. It's so you can pin them to each other, it's so you can pin them together, it's so you can pin them to someone's clothing. And then you would tie this up here with a square knot. And that is how you would both splint and sling a broken bone with a SAM splint.
Can you demonstrate from the beginning?
Yes, of course.
There's
Now-
also an optional step of tying this
Yes,
to the brace.
that's not optional. I would just need to grab the gauze.
Okay.
Yeah, that's why I said you want to tie it on using gauze, you want to try it on using
Whatever.
using duct tape, gaffer's tape. Memorably, I believe I've done it with electrical tape. Is that what we had in the car that day? With the guy in the car accident? That was electrical tape.
We have practice gauze that we're going to use for this.
This is the worst gauze. This has been absurd. Now, someone want to grab me scissors? I realize I don't have any. They're on the... Have your trauma shears in your kit. What? Ian will be back over to monitor chat in a minute. I assume we do have people.
We have a couple, yeah.
Thank you.
You can also just check on
Thank you very much. Okay. So you would want, so let's say that the break is right here. The place I'm not going to tie it is right on top of the break, especially if it's an open break. I'm going to tie it here, not directly on the break. We're going to pretend. And then I'm going to cut it. Bad scissors and bad gauze. Fun. Got it. We got this gauze for teaching a different demonstration. And yeah, it was a Stop the Bleed demonstration. And it took so much of this gauze to wound pack because it just would not. Please cut. Okay.
All right. This is now splinted. it is attached to the rigid thing that will, like, can I bend it if I really want to? Actually, in this case, not really, because there's no joint for me to bend it with across that.
Okay.
But that'll hold the brake still.
This, that point, that's what's going on the elbow. Okay? Sir, you're going to hold your broken bone for me. So that comes here. This, the back one that is closest to their body.
Do you want to sit me down for this?
Honestly, kind of. Thank you. If you were ever standing while I was doing this, that would be absurd. You are so much taller than I am. Then this one comes around here. And then it is tied behind the neck. It's very easy to do. And you're all going to get a chance to practice it. But that just basically secures it. And I'm going to want to check back here and make sure that that's actually holding that elbow. And ideally, if possible, pin it to their clothes. I'm not going to do the pinning to the clothes because Ian really likes this shirt. Okay, so that is how you sprint a broken arm. It's actually basically the same thing if it's broken up here. You're going to apply the splint here, which you can practice as we're going around, and then you're going to secure it to the chest the same way. If the shoulder is broken, that's a more complicated injury. At some point, I'm going to have to teach a class on broken joints because assessing and handling that is very difficult. I will say you will still use a sling. The sling is basically the same, but how you would actually bandage that is
To immobilize the shoulder.
Yeah, to immobilize the shoulder. Okay. If you don't have a handy dandy SAM splint, you can use, and you're all going to practice with one of these, anything you have laying around. Now I want to caution y'all, we did not have a chance to sand these. There are some splintery edges as these go around, but it goes in exactly the same place. You can use a second one. You'll often see in medic guides, they'll say put 2 SAM splints on, put 2 wood boards on.
Right. Do you want me to take this off so that we can show what that
Yeah.
looks like, even if we don't tie it all the way on? I'm healed.
It's a miracle. Now my brain is singing a song by Manson, and Manson is a horrible person. I don't want my brain singing his music, but it's definitely singing Personal Jesus. Okay, so
Depeche Mode, do that one.
is that Depeche Mode? Is that not Manson?
I don't think that's Manson.
Okay, well that's better. You would do it like this. I actually don't prefer this method. I prefer a single thing because in my experience, these like rock back and forth.
Right, you've basically created a limb sandwich and the limb is broken.
It's not good for the limb. And you also cannot do that if it's an open fracture that is coming through the top of that bone. You can't put something rigid on it. So I prefer to use a single one. And then the process is identical. Okay, now we're going to get into doing the leg, and I'm trying to figure out, I think you almost have to get up on that table for it to be seen.
Okay.
Well, you're going to get up on the table for transport anyway, so.
I don't know if that's going to make transport.
Oh, you don't think it should be Ian who gets up on the table? You think it should be me? Hold on, moving all the stuff.
Okay. I'm a little big for the table.
A little bit.
Hang on. There's more stuff.
Yep. That's really loud. Hey Lex, can that be seen on Zoom? Can that be seen on that? Okay, hop up. Which one are you? 36. Do I want to use the 36 or do I want to use, where's the one that got passed around?
Do you want to keep the 36 on the back?
Ideally. They're not cheap. Thank you. All right. Sir, if you could lay down for me. My lovely assistant, lay down as best you can. Okay. So it is basically the exact same procedure. You are going to probably, ideally, remove the shoe. let's talk about why you remove a shoe. You can sit up, love, while I talk about this. It is because of the swelling. They used to tell hikers that if there was reason to suspect that a bone was broken in the ankle, leave their hiking boots on. If it would enable them to hike out, it would add extra compression. And that is true in that set of circumstances. If they are walking wounded and keeping the boot on lets them walk. If instead you're trying to evac with someone to the medic tent that's set up, a little ways away, or you're trying to get them out of a dangerous circumstance, I would recommend take the shoe off because they can swell up and that shoe can then cause injury. Additionally, something to keep in mind is you're supposed to be monitoring the pulse and whether or not they can wiggle their toes and the pallor of the foot, and having this shoe on makes that a lot harder to do. So I say take the shoe off, except in the condition where you're talking walking wounded, trying to walk out of, having broken their bone on a hike. Okay, the procedure is the same. You take off the shoe. You're gonna take off your lovely shoes, Ian.
You may want to do the one closer to the camera.
That's smart.
Good try.
This is why they pay you the big bucks as compared to how much I get paid. Okay, I would also recommend that you take off the sock. Remember that you want to see the injury. Yes, this is probably going to hurt them. You're gonna get the pant leg either up, out of the way, or cut it off. If it's causing them a huge amount of pain and they're like yelling and screaming as you're moving it, just cut it off. Or just put the scissors up and cut a slit rather than trying to cut around their leg, okay? Then the splint goes on, and again, you stop, you don't put it over the toes. Now, one thing, if it's the ankle that is broken, is that you can bend the SAM splint and conform it around and have that. Again, you're going to want to leave, this is so much harder with you on this than it is with you just on the ground. You're gonna wanna leave the toes hanging out, just like when you had the toes or the fingers hanging free. Do not put the SAM splint on the toes, because you want to be able to go like, hey sir, can you wiggle your toes for me? Excellent, he can wiggle his toes. In the case of having it here, you're going to want to put one tie here, one tie here, one tie here, right? Okay, now I want to demonstrate how you do this with a pillow and how you do this with a towel. I don't know, I think you're gonna have to sit up on the table and have your leg flat. Everything goes sliding. In a pinch, you can do this.
Right. Let's say you don't have a SAM splint or any handy appropriately sized piece of wood.
You can do this with a towel or a blanket. Medics, you should be carrying a wool blanket with you anyway, always. Now I'm off camera doing this, but I'm going to narrate that I am rolling this up.
There is a towel that is being rolled towards the center from the shorter side. So being rolled lengthwise towards the center. It is now being rolled all the way
Rolled up.
into a tube.
And what you do with this is you wrap it very, very tightly around the injury, and then again, you're going to tie it in place. Okay? Just the same. You can do this with a wool blanket, you can do this with a sheet, you can do this with a towel. I wouldn't really say you could do it with a hoodie. There's not enough fabric there. But something like that. Okay?
Bathrobe maybe.
Bathrobe maybe, yes.
So this is to secure a broken ankle.
Yes, you can do it to the arm too. Where, again, it would end up looking like that. Okay. But it's a broken leg. You can do it up on the thigh, but it's not going to be this way because you can't do it like this. So I wouldn't say you can do it with this, but you can do the pillow method with that. So the pillow method is going to look really stupid, but it's what you do. You lift it up. And you just roll the pillow really tight around it, like as tight as you can, and then you tie that on. You can do this up at the femur too. Yep, you can use a sleeping bag. These are not ideal. You want to use a rigid splint if that's what you have available. I don't recommend you use a soft splint, but sometimes it's what you got. Okay, let's talk about evacuation. In the past, we have discussed various methods of evacuating people. We've taught it a couple times in this location. Those are on YouTube, they're on Patreon. We taught it as part of state violence-related injury. We taught it as part of lacerations and abrasions. It's more complicated if they have a broken bone. You really shouldn't be carrying someone slung over your back or in a fireman carry or any of that if they have broken bones, but sometimes you have no choice. The blanket carry that we teach, you really shouldn't be using if someone has broken their legs, broken their pelvis, definitely shouldn't be using it if they have a head or spinal injury, but sometimes, again, you have no choice. Have all of you been here for the blanket carries? Okay, you have not. So I'll make sure that before we leave today, I cover that with you. Do we have enough people here?
Yes.
Yeah, okay. I want to note that sometimes you have to fashion a backboard because you don't have one. How many of you even have started putting together your kit? Hey, cool, excellent. Backboards cost anywhere between $125 and $700. They're not cheap, but they're not small, but you can fashion one in an emergency. Yes, you can put your shoe back on. You can fashion one in an emergency. And one of the things that you'll probably have around you at something like a fair, these folding tables. They're not great. They're heavy, they're awkward. People can roll off of them. There is a debate in the street medic community as to whether you should tie someone to the table. If you tie them to the table and it moves, they're not gonna fall off. But if you tie them to the table and then you drop it, then you've also dropped the table on them. I see both points.
So in particular, I'm going to talk a little bit more about this. The thing with a backboard and tying someone to it is it's designed for that, right? It's got sort of this concave shape. It's got the specific slots that you're putting the webbing through. You have the right tool for tying someone down. You're using crash webbing. And you can get half a dozen tie points on a person at exactly where you want them. Mm-hmm. And they'll stay there. This means that you get to the point with that equipment where someone's tied down and you can take it and flip it around like one of those signs on the median and they won't come flying off. I don't recommend it.
But you could.
You're never going to get to that with this.
No.
This is a completely flat, hard surface. It does not have tie-down points. If you're really worried about not being able to keep it level, go ahead and add a tie, I guess, but you can't immobilize their body with it. Not like you can on an actual backboard.
Right. I know, you and I have different opinions on it because I'm on page tie them to it.
I know.
And you're on page don't.
Well, I'm on page you will never fully immobilize them, but if you're worried about them sliding off, sure, tie down in a couple of places.
Yeah. And I mean, Yen and I disagree about stuff. It happens.
Yeah.
And get two medics in a room together and you've got an argument. Okay. We will teach on carrying with this here in a minute. Does anyone in Zoom want us to do the blanket carry while they're watching? Or is everyone in?
There is one person left on Zoom.
Okay.
If you are able to, if not, no worries.
Okay, let's go ahead and teach it. It's going to require that, Lex, if you could hold that little camera that's on top of the...
We can just tilt it.
Oh, you're just going to tilt it. Okay, let's shift this.
Yep.
The mic stand is also good.
I'm going to just shift it slightly.
Here, let's just.
I want to use the smaller one.
Okay.
They're way easier to use.
And also they're easier to move back. Where they go.
This is actually the blanket from my kit. It is 100% wool. I use 100% wool ones even though they are expensive because you can also use them to put out fires. And if somebody's on fire, I'd rather the blanket that I have be able to be used
It just
cross-personally.
gets to be a little bit in the way because that's also our audio source.
Right, but that's if you put
We-
the blanket next to
we
it.
should-
Let's put the blanket here.
And then we'll be off camera. I'm just going to shift it slightly. Like,
Yeah, you'd only get like 75% of what, not even.
Oh, okay.
there. It's still picking us up, right? You want me to be the one on the ground?
It's probably easier.
What, you don't think we can carry you? We did last time.
Well, more. I assume that we aren't doing the actual carry because we're still recording, and that
Yeah.
will put everyone on camera.
Ah, yes. Okay, so one thing to note about this, if someone has a broken bone, is it's not ideal. You probably shouldn't be using this. The person is likely to get jostled with it. That jostling is not going to be kind. If you have to, ideally splint them first to stabilize the broken bone, then haul them out in the blanket. If you're going to haul someone around with a blanket, try not to do it for very long, partially because it's really heavy. And if you drop them and they have a broken bone, now you've really, that's not very kind. Okay. Ugh, I'm on the ground. You're gonna have to pull that slightly that way.
Are you visible on?
Okay.
What about on that one?
Can you tilt that
Can you
one?
tilt that?
Do you know how? And then bend it. Do you need help? There you go. Am I on?
Yes.
Excellent. Good job.
Okay. What we're going to do is accordion fold this to about the halfway point. This is always very awkward with just one person.
Yeah, it's much easier with, and you should always have a buddy as a medic. Do not make the mistakes that led to me getting stabbed.
Just gonna call yourself out. Okay.
The many mistakes that led to me getting stabbed.
This is tricky if they have a broken bone. One of the reasons not to do this. I am rotating her this way, scooching this that way, and then rotating her back.
Ideally, if there's space, don't roll them onto the side with the broken bone.
Yeah.
You know, if it's like broken that leg, don't roll them towards that broken bone. Put the blanket on your other side.
Yeah. Now get the blanket there. Ideally, she would be splinted. We didn't bother with that because there's no actual break.
Okay. And then,
If there is just you, you get to gather this on the head side because the feet can drag more easily than the head
okay,
and pull. If there's a lot of people,
each one takes the corner and lifts. When you take that corner, I'm gonna hopefully have this on camera. Don't hold the blanket like this, right? Hold the blanket like this. Get a nice big grip on it. One person each corner. Ideally, if you have enough, one person stabilizing the head. Just cupping. Yeah, if you're worried about spinal injury and injury to the head, you're gonna want to like cup the back of the head like so, and carry that in the blanket. This is something where you need a lot of people for it. You want to tilt that back up and tilt that back up.
Yep.
Okay. I don't recommend this if someone's got a broken bone. I recommend that you look around and find something. You can use a piece of plywood. You can use a folding table.
CERT would disagree.
What?
CERT would disagree.
I'm aware. Yeah. CERT does not recommend that you use plywood because if somebody's really heavy, it can break.
I don't think they understand the weight that is required to do that.
that.
Yeah. Chair carries are great for if someone has a broken bone because it's very stabilizing. You can use a folding chair for a chair carry. You cannot use a swivel chair. And if a folding chair is being used, make sure it's really locked open.
You can use a ladder as an impromptu backboard.
Yep, you can use a ladder. It's just most of the time, no one's going to have a ladder. Now, if you're doing like evacuation of a community after an earthquake, a flood, etc., then there's a chance that a person has a ladder, and you can ask them, you know, hey, I've got to carry you out of here. I think you have multiple broken bones. There's nothing I can use as a backboard. Do you happen to have a ladder? But be aware they're heavy in addition to the weight of a person. And they're very uncomfortable for someone to be strapped to, but it is an option. I guess at this point, I will demonstrate a chair carry, and then we'll be done with the portion that's getting shared, and we're going to pass out supplies, and everyone's going to get to practice things. Sound good?
Yeah.
Want to grab a chair? Hey, we are right on time.
Yes. We do. Sorry.
Okay. So, ideally, I'll do it. I'll be the sitting person. You can lift someone. Ian, will you demonstrate lifting me into a chair?
Sure. Although normally, so what I'm going to do is go under the arms and then cross my arms on her crossed arms and lift up and into the chair.
Okay, and then what should I do? Do you remember?
I'm going to ask you to cross your arms.
Assuming this is a broken leg. If it's a broken arm, they should be able to walk themselves to safety.
Right.
But assuming this was a broken leg, which is why I had him demonstrate lifting me into the chair, because I'm assuming at this point I can't stand or walk.
So then we are going to tilt this
Back. The second person is going to grab.
and 1, 2, 3 and lift. And we are not jostling the broken leg much. And down.
Okay. Chair carries are great. They actually really well distribute the weight of the person. They're actually okay for someone that you are suspected had like broken ribs. They're not great for something like a pelvic injury, but really the only thing that's good for a pelvic injury is like a full body splint. Okay. Any questions while we are still recording? Questions, comments, snark?
Any questions from our Zoom audience before we end the virtual portion of this? Okay,
All right.
I'm going to go ahead and end the Zoom meeting for everyone. If there was a short list of med supplies to bring to a protest, what would you say?
Oh gosh. I do have a recommended list. If you check out our slides, our notes, and our video on state violence-related injury, there is actually a first aid kit for just anyone who's attending a protest that went on that list. It is not the street medic kit. The street medic kit gets a lot more involved. We were trying to talk about what we wanted for our November classes. Would everyone like a class on put together your kit?
Yeah, definitely.
Okay, then that's, I will make sure that that's a November class. And we'll go over the list of everything I think should be in it, but I will also break it down into prioritizations. Start here by these first, then add these, and you sort of grow it over time. I don't have everything I want for my kit. I donated a lot of stuff during BLM when I thought I would never be a street medic again. I was very, very sick. Nobody could figure out what was wrong with me. I thought I was never gonna do this again. I was like, I guess I'll teach other people but not do it myself. Donated my entire kit to other street medics during BLM, and then I was like, oh, they did figure it out. And by them, I meant I did, and then I gave them enough hints to figure it out. And I'm in treatment, and I'm fine, and I'm back to being an active street medic, and now I have to buy all that stuff again. So it costs about $750 to fully outfit one medic, just so you know. Like, okay. Then that's what we'll teach in November. Now let's do the practical. Bye, everyone in Zoom. Whoever's left.
Bye, Zoom.
Be safe out there, everyone. Okay. We're gonna have to